everyone, and welcome to our session on the new palliative just-in-case kits for community. My name is Vicky Kennedy, and I'm a regional clinical nurse specialist with the Palliative Care and End-of-Life Services team, co-presenting today with my colleague. Elizabeth, would you like to introduce yourself?
You bet. Hi, everyone. Elizabeth Antifo. I also work as a regional care specialist in palliative end-of-life care. I'm Vicky's partner, and I'm located in Nelson, BC.
So I would just like to do a traditional territory acknowledgement. I acknowledge with respect our work and meeting places within the ancestral, traditional and unceded territory of the 7 First Nations of the interior region. We are thankful for being visitors on this land and strive to be mindful of the connection it holds to the Aboriginal peoples of this territory, as well as the animals and plants with whom we share this space. So objectives of our session today are to provide the background and introduce the IH palliative just-in-case symptom management kits for home health. The symptom management kits and the tools within it have gone live as of June 1st, 2020. We will then discuss the just-in-case prescription and clinical decision support tools to support home-based palliation, discuss the roles of the healthcare providers that are involved in implementing these symptom management kits, and then talk about activating the just-in-case symptom management kit. Here's some background on the development and implementation of symptom management kits in the community. The need for palliative SMKs in home health has been communicated from the point-of care home health nursing staff across the health authority, and particularly in rural and remote communities for quite some time. There has been only one community in interior health that has had a formal structure and process for SMKs up until now. We know that there is limited and variable access to prescribers and pharmacy services, and this equates to barriers and delays in parenteral access for some management, whereas a rapid decline in the condition of a person who is palliating at home, particularly on weekends and statutory holidays. So I identified that we needed to have a standardized structure and process to support timely, in-home, individualized palliative symptom management kits across the health authority. Having an individualized contingency medication kit is not intended to replace a regular prescription. It is essentially a backup or plan B and provides anticipatory planning when there are symptom emergencies where a person would otherwise end up in the emergency department. We were actually, that being Elizabeth and I, on a provincial working group to standardise palliative symptom management kits in alignment with healthcare regulations, including the BC College of Pharmacists and BC College of Nursing Professionals. However, that was put on pause towards the end of last year. Now, it was an identified need, and as part of our response to COVID, we reprioritised this work in March and received permission from the Ministry of Health to adopt and adapt the prescription. It was in the final stages of development and approval last year. We would also like to acknowledge the Central Okanagan Palliative Program team leads for sharing their tools and processes. We've adopted and adapted some of these as well. So in our development process, by obtaining permission from the Ministry to use the draft prescription, we adapted it and created, adopted and adapted tools to support use of this prescription in the community. We sent the package out for stakeholder review and feedback to clinicians IH-wide, community pharmacists, the Professional Practice Office, First Health Authority and Medication Management, as well as the BC Emergency Health Services. We also consulted with the Patient Voices Network, who reviewed and provided feedback on the patient handout. And I also consulted with Dr. Norman Buckley from McMaster University's Michael de Groot Institute for Pain Research and Care and Dr. Owen Williamson from BC Pain regarding opioid diversion risk and whether it was appropriate to use an assessment tool or to screen for the intended palliative population. The result of this was the diversion risk screen, which we will speak to a bit later. We followed due process by taking the package through Pharmacy and Therapeutics, as well as the Health Authority Medical Advisory Committee for endorsement and approval. The documents that are intended to be in a permanent part of the health record went through the Clinical Records Committee and received endorsement and approval. For those documents that can be charted on and used in the electronic chart, we have consulted with Clinical Informatics, and that is still pending. So we'd like to introduce you to the package. 10 clinical decision support tools that make up the toolkit and will be housed in a toolkit on the palliative care page of Clinical Care Resources in the Inside Net. We're going to go through the process algorithm and the tools within it. A successful quality palliative care really is a team sport which requires good communication and responsiveness between all the team players. The physician, nurse practitioner, home health nurse or advanced care paramedic may collaboratively initiate or activate the just-in-case symptom management kit. Home health nurse that will typically lead the process. The algorithm supports the process, and it is important to remember that the client and family are integral partners in the entire process from beginning to end and require the full support of the team. This is the algorithm, so we will take a few moments to go through page 1, which is initiating the symptom management kit, and Elizabeth will go through page 2, which is about activating or accessing the symptom management kit. So it's up to the home health nurse, physician and or nurse practitioner to collaboratively determine the eligibility for a person on the palliative program to receive a just-in-case symptom management kit in an anticipatory and timely manner. So on this slide, you can see that down the left-hand side, it identifies the healthcare providers that are involved in initiating the symptom management kit, and on the side, it identifies their role and responsibility. So a person would be eligible for a medication kit if their palliative performance scale score is 40% or less, experiencing a rapid rate of change, and or there are other clinical indicators that they are nearing the end of their life. In addition, having a conversation with the person and or family asking 5 open-ended screening questions helps to determine the risk of opioid diversion and guides teams to mitigating the risk. These 5 open-ended questions are listed in the eligibility and opioid diversion risk screen document, which can be found in the toolkit on the Inside Net. Prescribers were a key stakeholder invited to provide feedback during the development of this work, and the implementation of these kits being communicated to prescribers as well. We have created a memo which can also be provided and used as a means of ongoing communication. In addition, a standardized fax request has been created to accompany the symptom management kit prescription form when being sent to the prescribers from the home health nurse. This fax request provides information on the SMK and what you are asking the prescriber to do. It is up to the prescribers to fax the completed prescription to the pharmacy and the home health centre listed on the fax request form. The pharmacist's role is to fill the prescription received, provide family with a copy of the palliative just-in-case medication kit patient and family handout, and answer any questions the family may have when the family pick up or the pharmacy delivers the kit. His role is to determine the need for medical supplies in the home when they receive a copy of the completed SMK prescription from the prescriber and organise the supplies to support the kit. Then they'll review the patient and family handout, which supports accommodation and education with the family on the need for the kit and their role in using the medications from the kit when it has been activated. It is planned and provided to the family to ensure all necessary components of implementing and activating medications from the SMK are covered and, most importantly, understood by the family. And not least, it is the role of the home health nurse to ensure documentation is completed in the chart and on the medication log, on labels, and only have the medication record available when the kit is activated and a copy of the prescription on the side or top of the fridge. EHS or BC Health Services are key partners in this implementation as well. Advanced care paramedics, so not community paramedics, can now treat and release, which means they can access the SMK in the home. They are required to look for the prescription on the side of the fridge or top of the fridge, and they're able to give medications within their licence. Class 56 exemption to give hydromorphone is in development but not yet approved. If advanced care paramedics activate the kit, they will need to document on the medication log found in the kit and follow up with a phone call to home health. And now I'm going to pass it over to Elizabeth to continue.
Thanks, Vicki. So I'm going to walk you now through the second half of the symptom management kit algorithm and summarize the process looking at the various forms that are going to support you in your practice. I ask you to give some thought around the role that you have in this process, what those details might look like as we activate this work within your workplace itself. The first part of activating the algorithm, next page please, Vicki. The part of activating the algorithm is about when you should use it. And so being able to determine the need to move from parenteral medications from oral medications is important. It's often because of sudden change in symptom distress in which the ordered oral meds will not work anymore. And some of the reasons for that loss of the oral route might be an actual or anticipated loss of a swallow reflex, which we know is often reflected in a falling PPS from between 30 to 20%. So we anticipate, when we see a rate of change in a PPS, we can anticipate that that swallow reflex may be coming up, and it may be timely and appropriate in a proactive way to plan for that. And the reason that we might no longer be able to give oral medications to treat symptoms is that the gut is no longer absorbing well due to partial or full bowel obstruction, edema, or some with extensive ascites. Vomiting are also another obvious reason to switch from oral over to parenteral meds. I would ask that you use your clinical judgment in deciding when it is appropriate to activate the symptom management kit for an individual. It really needs to be an individualized response. So like you've mentioned, who should access the drugs within the kit in the home? We designed this whole system to be accessed by either the time-limited home health nurses, a physician or nurse practitioner who may be in the home and providing a home visit, or an advanced care paramedic who might be answering a 911 palliative call. Let's talk about some of the considerations as you are in the home and you've made the decision now that you should be accessing this kit. So what do you need to consider? You're going to start by asking the person or the family if they have such a kit secured in the home and being able to locate it. Also, for a copy of the prescription form on the side of the fridge. It should be kept in the green sleeves or taped or magneted to the to the side or the top of the fridge. Check the subcutaneous line in place. If not, then you're going to need to start one. And there should be an accompanying bag of subcutaneous supplies within the home. So nurses, as Vicki mentioned, we have a standardized equipment list as part of this toolkit that can guide you to put the bag together. I will mention a little bit more about that in a few minutes. You can draw up the appropriate medication as per the orders and then administer it subcutaneously. Monitor the person for at least 30 minutes afterwards to ensure that you were able to obtain some symptom relief and adequate symptom relief. We would recommend that you use a pre and a post ESAS score when you're doing this work so that you know you're moving in the right direction. While you're waiting for the medication to work, you may be starting the work around planning for continuity of care. And this means organizing the parenteral symptom management kit medications for the next dose that needs to be given. We know doses could take 24, 48, and sometimes in some very rural and remote areas of our health authority, up to 72 hours before we can get regular medications in the home. So again, this is a contingency kit. It's a backup kit, and it's really meant on short-term basis to fill that gap. You pre-fill syringes for the family who are now going to be taking over the care once you leave. You want to make sure that you've labeled each syringe clearly with the medication name, the dose, the frequency with which it can be given, and what symptom that medication is being used to treat. Helpful if you have more than one parenteral medication to cluster the pre-filled syringes together in separate cups from other medications so that the family doesn't get confused. Waiting for symptom relief to take effect, you can also start your documentation process. And there's two documents that you will want to focus on. The first is the medication log, and it's actually located inside the symptom management kit bag. So with the parenteral meds, it'll be folded and in there. You want to fill it in and leave an accurate count of what's left in the bag after you've taken what you have used and what you have drawn up as a pre-filled syringe. Medication record in here is an in-home medication record, and this is a good time for you to maybe use this as an example for the family because they will have received instruction earlier during the education in how to use this form. So if you can enter into the first dose so that they have an example to follow, and I'll speak a bit more about this in a minute. If you are working in home health, and we would ask that you also go back and chart in Meditech when you've returned to your office. The last part of activating the kit is really around communication. It's important for the physician, the nurse practitioner, or the advanced care paramedic to know they have closed the loop by leaving a message for the home health nurse that they have access to the kit. Remember, because it's a contingency kit, somebody has to be in charge of now wrangling up regular parenteral meds, and the nurse is often the home health nurse is often the person to follow up on that. Home health will have left their local office number posted on the side of the fridge, so you can call and leave a message for them at any time of the day or night, and they'll follow up the next day. Nurse, as a special note, please realize that you are in this coordination role. You are the person who we are asking to be responsible to ensure that regular parental orders are followed up on and for ongoing symptom management. It may involve a discussion whether continuing with intermittent subcutaneous injections is the plan versus would this be a person who might benefit from having a continuous subcutaneous infusion pump, and would better support them in terms of their long-range goals. You'll want to determine when the next home visit should occur. At minimum, inquire back to the family around symptom relief and stability, and just check back with them. How are things going? There may be additional family education that needs reinforcing if they're feeling insecure. As it gets closer to death, just keep reminding the family that the contents remain secured within the home until it is no longer needed, at which time it will be returned to the pharmacy and its family, who usually returns it. The process. Let's go through some of the forms again. There's just a few more details around putting it right into practice. The back is the just-in-case prescription form. And nurses and advanced care paramedics, both of you could request that from the physician or the nurse practitioner. You get that fax form that Vicki identified and enter off one of these prescription forms with a request that the physician consider this for the individual you're seeing. Keep a copy in the chart and a copy in the home on the side of the fridge. As he's mentioned, the orders really need to be individualized based on clinical understanding and judgment about this person's disease trajectory and how things are going. What can we anticipate will be predictable symptoms at the end of life. Medications often are used for multi-symptom purposes. So opioids can treat both pain and dyspnea. And we often use haloperidol or methyltrimeprazine that can be used for nausea or for delirium. So the idea is to keep the kit small, minimalistic, and that less is more. The physician and the NP to take their best guess about what symptom relief at the end of life would look like that would avoid a necessary trip to the ED department and the hospital, as that's often not within a person's stated goals of care. Notice on the back of the just-in-case management kit prescription form that we have a dosing guidance. And I just want to reassure you that these are in full alignment with the BC Centre for Palliative Care Symptom Management Guidelines, which were officially adopted for clinical use in interior health in the June of 2019. As mentioned, when the symptom management kit is received, an accompanying supply bag is made up by home health. This also, this list serves as a guideline for you, recognizing that it may require local variation. So you have different stock, or you might be able to access different supplies. Use your judgment, but it is a general guide. Nurses, just note that this is a critical accompaniment for the symptom management kits because many of the nurse practitioners, the physicians, and even the advanced care paramedics are not carrying subcutaneous equipment with them. So they're going to be relying on finding this supply bag in the home before they can activate the kit. I have a nice example as well from up in the IH West, where there was some excellent collaboration and partnering between home health and one of the First Nation band employed nurses. We managed to support a gentleman to stay on reserve, and so the kit was actually made up by home health, and the First Nation nurse picked it up. We were able to put a kit in place. One of the other critical documents in the toolkit is the med log, and this is how you will provide accountability for the drugs you've taken and used out of the kit. Note that opioids are controlled substances, and the physician was responsible for sending a duplicate prescription when he or she ordered them. The home environment does not provide similar controlled substance safeguards as an acute or long-term care site. So we have to really adjust our thinking to realize that this kit belongs to the family, right? The med log, though, inserted into the bag by the community pharmacist, or it might be the home health nurse. And we would ask that you have a local conversation about what works best for both your practices and within your community. And I know that home health nurses have a very strong relationship with their community pharmacists. When I got work, the pharmacist was your friend. You'd be able to phone in and have that conversation. So figure out what works for both of you. The log must leave the bag after you've documented your use, and it includes that leftover count that I mentioned, and it is part of the client's permanent record. So it should be attached to the client chart when the kit is returned to the pharmacy after death. The third record we have is the client medication record, or in-home medication record as we refer to it, and it's really just a simple worksheet that is a way of helping keep the family straight in what they are actually giving and when they're giving it, as well as noticing anything like ESAS scores or responses to the medication. This is going to help us as health professionals untangle their use of breakthrough dosing and assist with any possible titration moving forward. While modeling the documentation that you give as the first dose, you're really using their earlier family education. Again, there's a worksheet and not part of the client chart. Brings us back to the original palliative medication administration checklist, and you may not find a copy of this in the home, but nurses will be using this as they're teaching the person and putting the kit in place, initiating the kit. And we recognize it's a process, and maybe more than one nurse who's providing this education, and people make more than one pass at a particular step in being able to understand the role and how to do this safely. So being able to revisit this and then sign off for those pieces of education that you're actually providing to the person. What we want is them to feel comfortable and confident to continue symptom management once the initial healthcare provider who activated the kit has left the home. Additionally, the patient family handout can be used throughout the process, and this is really about supporting family understanding. And again, it could be used in that very initial conversation that you might have when the family is considering whether or not they will use a symptom management kit in their home. Physicists might be using this sheet when they're issuing them medications for pickup or delivery, and so they often will go over the medications and again, the process, helping people understand about keeping it safely in their home and returning it after it's no longer needed. The home nurse can use this during the teaching and education sessions on how to administer parenteral medications. It can also be used when the kit is actually activated. So when you're in the home, you've activated it and used the kit, and if there's a copy of this handout in the home, it's a nice time to be able to reinforce people's learnings, particularly in a stressful time. This form is located on the inside net and external net in our toolkit, so it's readily available to everybody. So that's to the summary. These individualized symptom management kits that are ordered just in case, and it's really about supporting a person who has said that they wish to stay home as long as possible and to avoid any unnecessary trips to the emergency department or the hospital. It's closing that gap, the gap between when we recognize symptom distress and realize that we need parenteral medications. That time gap can be quite long in rural and remote sites where we have to obtain physician or nurse practitioner orders, and then it has to be filled, it has to be delivered or picked up, and then finally administered. And that's a very long time for people to suffer. So by having access to parenteral meds in the home, we're hoping to close that time gap. We hope that you have a very positive experience in implementing these kits and initiating them. Toolkits are on the inside and external websites. If you have any questions, you can call Vicki or myself or email us, and we'd be happy to walk you through the process and assist you as you begin to implement it. Thank you.